I like to present a 72 years old male cigarette smoker who was admitted in our unit with pain in left upper part of the chest for the last 3 months. The patient also complained of intermittent pyrexia, dry cough, weight loss, and hoarseness of voice. Initial sputum examination was negative. This is the chest radiograph of the patient. The film is hyperinflated and there are two opacities, one in the right paratracheal area and the other one is in the peripheral area of the left upper lobe. The CT of the chest showed right paratracheal nodal mass and patchy subpleural opacities in the left upper lobe. Here you can see bilateral lymph nodes. This is the CT scan of the patient. This is the mediastinal window. And this is a closer view that shows the right paratracheal nodal mass and peripheral patchy airspace opacities. EBUS TBNA was done at station 4R in another hospital and the histopathology remained inconclusive. And this is how the patient presented with. So we plan to do a flexible bronchoscopy with trans-bronchial lung biopsy under fluoroscope guidance. And here you can see the scope is inserted via the inferior segment of the lingular lobe, and then the catheter was traced on the fluoroscope, and you can see the catheter is passed in the peripheral lesion, the lung lesion. The catheter is passed under direct fluoroscope guidance, and then the biopsy is taken. Fluoroscope guidance is the X-rays guidance under which you perform your procedure, the interventional procedure. Either you can have a fluoroscope in your interventional bronchoscopy suite, or you can take the patient like us in the radiology unit for obtaining the fluoroscope guided procedure. So this patient was taken to the radiology suite and we did the procedure. You can see that the bronchoscope was wedged in one of the subsegments in the lingular lobe, and then the catheter was advanced until it reached the peripheral lesion where the bronchoscope cannot normally reach. So the catheter is advanced under the X-rays guidance. You reach the lesion, you open the biopsy forceps, and you take the biopsies under direct vision. So we took 5 bites of the lesion and we could make a diagnosis of tuberculosis. The histopathology was consistent with chronic granulomatous inflammation, and Zn staining, AFB stain, was also positive for tuberculosis. So this was the final diagnosis. It was pulmonary tuberculosis presenting as peripheral left upper lobe opacity or consolidation.